Good morning, welcome to the Gimbal Eye Center. It's July the 24th, 2012. Our patient this morning is Crystal Chalmers, and Crystal's having left eye cataract surgery today. Our surgeon is Dr. Howard Gimbal, and as this is our patient's second video, we'll abbreviate the surgical description a bit. So, 2 incisions. First incision there at about 8 o'clock, and then topical anesthetic is applied to the surface of the cornea and then into the anterior chamber of the eye. That's the front chamber. Then the chamber is filled with a material called a viscoelastic, gel-like substance that will protect the tissues of the eye during the cataract removal. 40 or 50 years ago, cataract surgery used to involve a 2-week stay in hospital and a couple of days of having the head immobilized. There were sutures involved and lots of precautions to take post-operatively. And now they are sutureless. The patient is wide awake throughout. Here at the clinic, there are no local anesthetics or gurneys or hospital gowns or blood tests, all of those things that just add to the tension level. And as the light level's turned up, we see the posterior polar cataract there right in the center of the pupil. So that incision is 2.2 millimeters. There's technology available that allows for incisions even smaller than that. Back in the early 80s or late 70s, the incision was about 7 or 8 millimeters, and so sutures were required. But incisions here have been sutureless for about 20 years. So now the capsule opening. This is a method of opening the lens capsule that Dr. Gimbal developed to address some problems that cataract surgeons were having back in the late 70s, early 80s as the lens technology changed. So the round capsule opening helps keep the capsule intact as the cataract is removed. It also helps keep the implanted lens centered as the eye heals. Prior to this, the surgeons would open the capsule with an incision and then pull aside 2 flaps, which created issues with the new lenses as well as the techniques required to completely clean the capsule to prepare for those new lenses. So he's going to open the capsule with a cystotome rather than the forceps. Sometimes in the younger patients, the capsule is a little tougher and requires this instrument to make the initial puncture rather than the jaws of the forceps. So there's the puncture. Now the forceps will be back. So because of the importance of constructing this opening correctly, it's considered one of the more critical parts of the surgery. Typically the capsular excess is 5 millimeters in diameter. It needs to be centered in the patient's visual field. And the round shape is important as well. That helps keep the lens centered. It also helps facilitate the cataract removal because it's a perimeter that isn't likely to tear as the cataract removal process goes on. Now this is where the removal of a posterior polar cataract will differ a bit from a more typical cataract surgery. Fluid is often used to separate the cataract from the capsule, but because the posterior polar cataract sometimes weakens the capsule on the posterior side, here Dr. Gimbal does the dissection just mechanically, just lifting the flap of the capsule only, with no fluid around the back surface of the cataract that could possibly lead to problems with that posterior polar cataract development. So same thing with the ultrasound. The technique is different here than it would be with a more typical cataract. The material around that cataract development will be removed very carefully, and the posterior polar portion will be removed toward the last. The rest of the lens material is quite soft. Only that button of material in the middle at the back. This is a cataract removal process that was invented by Dr. Charles Kelman back in 1962. He was inspired by a visit to his dentist, who used an ultrasonic instrument to clean the tartar off his teeth. So it looks like that capsule is intact. It's removed a portion of the posterior polar development. So far, no ultrasound has been used, just a bit there. Now a spatula inserted to help maneuver the remaining lens material. So topical anesthetic applied here. I think that's what he's doing anyway. We may see the next handpiece here. A little pause in the proceedings. Now he'll do a little hydrodissection after some of the cataract has been removed, just to dislodge this portion of the lens from the capsule. Typically the hydrodissection allows the surgeon to rotate the entire cataract inside the capsule. He needs that mobility to effectively remove it. With a posterior polar, there is no hydrodissection, so it does it a little later and then maneuvers this last fragment. So we will use the I&A tip to remove the rest of the cataract. The material's pretty soft. So far, no ultrasound has been used to speak of. This is an instrument that doesn't have the ultrasonic function, typically used for the capsule cleanup prior to the insertion of the lens. So he'll remove the remainder of this lens or cataract material with suction only. So still tiptoeing around that posterior polar button, and it looks like it's been dislodged from the capsule now. So it's that tiny little button of cloudy material that causes all the vision problems. It's right in the center of the visual field, which is one of the reasons why it has such a big effect. So now the capsule cleanup. Scrubs off a layer of cells called lens epithelial cells. Sorry?
So the sac that holds the lens in place is still intact?
Yes. Yep, lens capsule still is intact. That's the worry for the surgeon, is that the posterior polar cataract can sometimes weaken the capsule in the center.
And then it falls into the back of the...
Well, or a tear develops. So this is a scrubbing process that only an experienced surgeon would do. The cataract surgeons weigh the risk and reward as far as the capsule cleanup. Sometimes these cells will regenerate and cause issues with the vision. The treatment is a fairly straightforward laser procedure that removes the cloudy portion of the capsule that has had that cell regrowth.
So there's that small
Still a bit of cortex there that he'll tiptoe around, it looks like. And it's off. So capsule's still intact, that's a good thing. So he'll carefully polish the back of the capsule now, removing those lens epithelial cells as well as any remaining cortex fragments. All right, that concludes the use of the I&A tip for now. Sometimes there are cortex fragments trapped under the incision that can't be reached with the I&A tip. So the capsule's filled with a viscoelastic material again. And we will either see cortex cleanup or next step would be the insertion of the lens.
So the stuff he's just putting in the eye, that you just expand it so there's more room to work?
Exactly. Yeah. It sort of inflates the capsule, creates some space for the lens. So the lens is inserted into the eye, occupying the same spot in the eye as the natural lens did, and it unfurls inside the capsule and is positioned initially by the haptics. The lens is an acrylic material. The foldable lenses have been around since 1983. Prior to that, they were made of derivatives of plexiglass, and so they weren't foldable. So even as the technology for cataract removal changed, because the lenses weren't foldable, the incisions were still between 6 and 8 millimeters. So a lot of surgeons couldn't see the point of making the change to the ultrasonic technique because they had to enlarge the incision to finish the surgery anyway. When the foldable lenses came along in '83, that was a big change. They were silicone-based. The lenses we are using here today are an acrylic material. So the viscoelastics removed now with the I&A tip. The viscoelastics themselves, they've been around for about 25 years. They're based on methyl cellulose, which you will find in some food thickeners, or also sodium hyaluronate or hyaluronic acid, which occurs in our connective tissue apparently. You'll see it advertised as being in some cosmetics. They're engineered to be biocompatible, so anything that is left over in the chamber breaks down and is removed with the normal regeneration and recirculation of the aqueous, which is the fluid in the front chambers of the eye. So still removing viscoelastic here from behind the lens.
It's very similar in texture to probably a contact lens.
Well, like a hard contact lens. We see a few different lenses here at the clinic. The Alcon lens, Alcon says it's an acrylic material and it's hydrophobic, so it doesn't have an affinity for water. Some of the other lenses that are used here are a different sort of acrylic, and they are hydrophilic, more like a soft contact lens. And we have other lenses used here, implantable corrective lenses that are Collamer. So they're a combination of natural and synthetic materials, and they're hydrophilic as well. They're actually a combination of collagen and polymer, so that's the term Collamer. So lens is in place and unfurled. Now the wounds are sealed up.
Why are they sealed up?
They are sealed with a couple of different mechanisms. First of all, the way they're constructed. The large incision is about as deep as it is wide. The surgeon calls that a square wound, so lots of surface area. So that surface is hydrated or moistened, so the structure swells slightly, swells the wound shut. And also they tend to act like one-way valves as the pressures are adjusted and the chamber is reformed. So this is hydrating here. Sometimes there's also a little lip on the floor of the wound that Dr. Gimbel likes to make sure is in the chamber and not back in the wound. Repositioning the lens. At several points here, the surgeon asks the patient to look directly at the camera light. That's to help him center the lens in the visual field. So it may not look centered in the pupil, but our pupils don't always dilate symmetrically. So this is antibiotics. So that overlap that we see of the flap of the capsule onto the front surface of the lens, that's part of what seals together as the capsule shrink wraps around the lens. That overlap seals together. The capsule shrink wraps around the haptics of the lens, so it's anchored quite securely. That takes a couple of weeks.
I see there's those hooks on the side there, that's to keep it from moving around. Yeah, those.
Yeah, those extensions from the optic of the lens are the haptics. So they do the initial positioning, but it's that encapsulation that really holds the lens securely.
Because the lens bag itself eventually just folds in around the lens, though?
Well, the capsule shrink wraps around the lens, yes, that clear membrane that's left. So antibiotics again. And now check of pressure and check of firmness again with the sponge handle, and that concludes the surgery. So that one went just as smoothly as the first one.